Hello, this is Kathleen Lisson, and welcome to my presentation of oncology massage after breast reconstruction. So let's pull these slides up and get started. Okay, so I am a lymphedema therapist, a board-certified massage therapist, an S4OM preferred practitioner, and a NCBTMB approved continuing education provider. And today we're going to talk about a lot of topics. We're going to talk about why do people have reconstructive surgery after breast cancer? What has changed over the last 10 years of breast cancer reconstruction? We'll look at some research together. We'll also look at massage after breast reconstructive surgery involving breast implants, which is what I help with in my studio in San Diego. We'll look briefly at the medications our clients may be taking to reduce their incidence of capsular contracture, and we'll talk about capsular contracture. And then at the end, I'll briefly go over some information about breast implant illness, which is something I want you to kind of have in the back of mind or in your back pocket when dealing with clients with breast implants. So first, let's get started with the big question, and then we will really zero in on my specific clients that I help. So the big question, why do people get massage after cancer surgery? And let's look at our first piece of research. This is from researchers at MD Anderson Cancer Center. They looked at the charts of 473 patients referred to an integrative oncology clinic, and they found that most of the referrals were for stress, relaxation, pain, or anxiety. And then those symptoms would get the client referred to an integrative oncology clinic and recommended for oncology massage. And the ESAS is the Edmonton Symptom Assessment Scale. I always love looking at a good assessment scale because it gives us the idea of what clinicians are looking at as far as symptoms, and it gives us the opportunity, if we're having a conversation about oncology massage, we can refer this to this scale. We can refer to some of these symptoms that are on the scale. And if you are having a conversation with any clinician about oncology massage, I'd recommend citing this study, and all the research is going to be available in the resources section at the end of this presentation. So we'll get smaller and more focused on what I do in my office, and we'll talk about why do people have reconstructive surgery after breast cancer, because this is for the main part, the client that I am helping has reconstructive surgery after breast cancer. So many people seek to reconstruction to reestablish the breast shape and the breast volume, and it is thought to limit the adverse biopsychosocial impact of mastectomy, restore the patient's body image, sense of femininity, as well as improving quality of life. It's important to know that there is an alternative, which is called aesthetic flat closure, where the breast mound is not reconstructed, and that's something that some people do decide to have, and it's an equally valid choice. It's each person's choice after breast surgery what they want to do as far as reconstruction or not reconstruction. So when we're looking at reconstruction, we need to know that there are still some disparities. There is not true equity in our healthcare system in America. So let's look at a second piece of research. It's from researchers from the City of Hope, which is a research and treatment organization in the US, and they talk about the effects of federal mandates. So we're going to talk a lot about what's changed over the past 10 years, but first I want to look at what's changed over about the past 25 years, because there are some oncology massage therapists that have been in practice for over a quarter century, and I would love to ask them and hear about their experience in practicing with clients with breast cancer in the early to mid 90s versus how is it now, because the effect of the federal mandate has resulted in almost all rates of breast reconstruction doubling because of a federal mandate that provides protection and resources to people that have a breast cancer diagnosis. But we need to know that despite federal mandates like the Women's Health and Cancer Rights Acts of 1998, access and use of care is still unequal in America. So researchers looked and they had found disparities in breast reconstruction in clients who were minorities, clients that have public insurance or no insurance, clients in rural areas, in low income areas, low income clients. It's about the access to having a community hospital and really the access to a breast surgeon in the community. And whether they're English speaking or not, you can see the result in people having less access to reconstruction surgeries. So it's important to know that all of our clients' experiences with being offered breast reconstruction may not be the same. So what has changed over the last 10 years of people who have had reconstruction after their breast cancer? And another really great piece of research, over 3,000 immediate implant-based breast reconstructions. The doctors who authored the study looked at their records back 10 years at Mass General Hospital. And here is what they found. They found that the type of surgery that they're doing has changed in the last 10 years. And if you would talk to somebody who has been an oncology massage therapist, helping patients, helping clients after breast cancer surgery for over 10 to 15 years, I think you would see this reflection in the way that our practice has differed. I have definitely seen in the past 9 years a difference in the type of breast cancer procedures that my clients have undergone. I see a lot more people with breast reconstruction where they have their nipples. I see a lot more skin flaps, and the researchers said that they've gotten improvements with skin flap vascularity. And then from the total muscle coverage to the partial muscle coverage of the breast implant. So we'll kind of take a step back and look at what are the different types of breast cancer reconstruction. So I talked briefly about flaps, and we looked at it in the research in the previous slide. So a flap is, you may hear the term tram flap or deep flap. That's when the microsurgeons will take a piece of tissue with the skin and underlying tissue from the abdomen or from different areas of the body, and then place it up into the breast area to help them recreate a breast mound. So that can be taken from the abdomen, and then it will be called like a deep flap or a tram flap. And then it can also be used, the surgeons can also use an implant in the reconstruction. So that is, it's always covered in silicone. The outside is always silicone, and then the inside is either a silicone or a saline. And then that medical device, that breast implant, will be placed underneath the skin as an alternate form of reconstruction. You can also have a hybrid where they'll use a flap and they'll use an implant. And then I help clients who have an implant and then they have liposuction and a fat transfer. So the main options to keep in mind is the client can come in with a flap, like a deep flap. They can come in with a breast implant. They can come in with a hybrid, like some mixture or part of this, and then also liposuction and then fat transfer to the breast. So when I have clients that have like deep flap, I will mostly be working on the donor site area. The client won't come to me like 3 or 4 days after surgery. Usually they stay in the hospital for a few days after surgery. They have to make sure that the flap is surviving, it's vascularized. And then they'll come to me later and they'll be swollen in the donor area. So like in the abdomen, if that's where the tissue was, the donor tissue was taken from. And then I'll do manual lymphatic drainage of the abdomen. If it's an implant, you really have to let the surgeon lead you. because we'll talk about ADM, we'll talk about some different things that happen with implants. That means you probably shouldn't be in there in the first week doing kind of intense massage on their breast right after surgery. But what I will see, and what I do see most often in my office, is the client will have a breast implant, and then they will have liposuction, and the doctor will take the fat that is liposuction and place it in the breast area to improve the cosmetic results. So again, I will see the client a week to 2 weeks after the surgery, and I will be working on the donor area of liposuction, the liposuction donor area. So we talked a little bit about this. Most of the clients I see for breast reconstruction after cancer are from a surgeon that also uses liposuction and fat transfer to the breast. So where is this donor area for liposuction? This survey kind of describes where it's taken from, where it's put, and I put in bold what I usually see. The first area, the first best area is the lower abdomen, like below the navel, and the overall abdominal area is a great area to get fat from. Also, the medial thighs, especially if it's a client that's in a low BMI, they'll have to take from like the upper inner thigh area, and then also the flank. The love handle is a really great place to take fat. So when I do my massage, I'm doing it on the areas that they had liposuction. So when the surgeon is doing implant, they can do it a few different ways. They can do it one stage, which is direct to implant, which means the client will go in for their cancer surgery, and then after they remove the cancer, they will place the implant. So the client will wake up with a breast mound. And then you can also have a two-stage, which is the tissue expander is put in, and then that expands the tissue, and then a permanent implant is placed later. So this is where we're going to begin to learn about these acellular dermal matrices called ADMs. So they are placed on top of, it's like a mesh that's placed on top of the implant to cover the implant above the muscle or over the muscle. So it's important to know that this is kind of taking America by storm. Implant-based reconstruction is the most common method of immediate breast reconstruction in the United States, with these ADMs playing a significant role in supporting the implant and covering the implant. Because in people without a lot of fat tissue, the risk is, what you don't want is someone can see your implant right underneath the skin. So formerly they would put it, and sometimes they still put it underneath the pectoralis muscle. So you see the pectoralis muscle, you don't see the implant. And now some people are putting it on top of the pectoralis muscle and like covering it with these ADMs. So like is shown in this Grazia paper, in 39,000 procedures, the acellular dermal matrix are used in the majority of the cases. What's really interesting about ADMs, and here's a picture that I took at a plastic surgery conference of the ADM that was at one booth. They are not indicated for breast surgery. This is an off-label use of ADMs, but they are used, like we saw in the previous research, in many of the cases. So what you need to know is you do not want to move around the implant and the ADM if the mesh is used in the operation. And I had a surgeon tell me, 6 to 8 weeks is the first time, the earliest after that surgery, that they want them massaging the breast area. The ADM has to stay in place and do its job and have the body kind of keep it in place, and the body has to place tissue on top of the ADM. You don't want to accidentally move around what the surgeon has so meticulously placed in the operation. And the biggest change that I have seen in the past 10 years, besides the nipple part, prepectoral breast reconstruction. So there's a few different ways you can put the implant in the breast tissue. One is underneath the pectoralis major, and there's a hybrid one, which is, it's kind of underneath and kind of on top, and then pre-pectoral. So you have the pectoralis major and they're putting it, the implant is on top of that pectoralis muscle. And we're seeing more and more pre-pectoral breast reconstruction because of these acellular dermal matrices and because of some of the drawbacks from putting it under the muscle. So this is a great research study. They conducted a systematic review and meta-analysis of these two options for breast reconstruction, and they found putting it on top of the muscle versus underneath. On top of the muscle improved postoperative pain. It improves the breast Q score, which is another one of those the question surveys that are so valuable to understand what's really happening with the client. And it improved upper arm function because you're not jamming an implant underneath a pectoralis muscle and then expecting the shoulder to have regular range of motion with an implant jammed underneath one of the muscles in between the muscle and the rib. So let's talk about capsular contracture, because that's another big expense and a big trouble with putting a breast implant in the body is capsular contracture. So if you have someone after mastectomy, after breast cancer, after radiation, the incidence rates of capsular contracture are significantly lower in the PBR group if you put the implant above the pectoralis than if you put it underneath. And they state the presence of that dermal matrix is essential because it has a protective effect against capsular contracture. So capsular contracture, which is just like anything, if we put a foreign object in the body's going to make a capsule around it to kind of protect itself from this foreign body. So capsules get put around everything. Capsular contracture is a phenomenon that when you say capsular contracture, you mean specifically a breast implant. I like to think of it as like there's an oyster and then the little piece of dirt gets in the oyster or the pebble, and then the oyster makes a coating, the pearl, to cover that oyster and to cover the offending the foreign body and to make it protect it from the body. So this is something natural that happens in the body. The capsule, it happens to everybody. And usually a capsule is thin. Sometimes when you remove the breast implant and the capsule, you can actually read, if you put the capsule on newspaper, you can read the print underneath it. The problem is when it gets hard, when it potentially gets calcified, and when it's getting smaller and contracting. That's what causes pain in the client, and it causes a cosmetic issue as well, where the implant will start sitting, like you'll be able to see the implant. It may be sitting in the wrong area on the breast, and it's hard. I saw one mental image of it was, you think of the difference between like your nice bedroom pillow and like the sofa pillow and like a Nerf ball and then like a lacrosse ball or a tennis ball. So it gets harder as the contracture gets worse. So how common is capsular contracture? This is a big problem both after breast cancer surgery, reconstruction, and after cosmetic breast augmentation. A study of over 12,000 breast implants found the most common reason for breast implant revision is capsular contracture. So what's an alternative treatment versus taking the implant out and trying to put a new implant in? Some clients want to have liposuction and then graft the harvested fat to the breast, and that can be an alternative treatment for capsular contracture. So that the fat grafting in one study found it elevated the resolution rate, so the client was satisfied with the result in up to 86% of the procedures. And if you add fat transfer to a breast that has an implant with capsular contracture, they found that you can reduce the pain because it reduces that sensation of having a foreign body inside of your breast, reduces the feeling of tension, and then the feeling of cold breast, the breast just feeling colder than the rest of the body. So what about altogether? Why should people find liposuction and fat grafting to the breast after breast implant surgery helpful? Why should it be an option? It's possible to reduce the pain from capsular formation. We saw that just in the last slide. It can reduce the feeling of tension. It can reduce the feeling of just the breast feeling colder than the rest of the body. And if you can see a little bit of the edge of the implant, especially on a very, very low BMI client, this might help to disguise the edge of the implant. So this is a good thing to know in your mind if you have a client and she's been through the breast reconstructive surgery and maybe she has some of these concerns that maybe the liposuction, the fat grafting might be an option for her. And it would be great to share the research so she can make an informed decision with her doctor. Now, very interesting. I did a lot of research for my class, breast massage after implant and explant plastic surgery, and some of this research blew my mind. So here is, this is the thing that surprised me last fall and winter. Capsular contracture may be an inaccurate term when the client has breast deformity after radiation. And that is, they have found that the breast actually changes when the patient is under anesthesia. So this will be a client that had breast surgery, they had radiation, then they have an implant in, and oh, it's giving them trouble. They think it's because of the capsule. But when the surgeons put that person under anesthesia for the operation, the pectoralis major relaxed because it was under anesthesia, and the breast form changed. It changed. So here's the study that talked about it. The chemoparalysis of the muscle alone can resolve breast asymmetry, and that they felt corroborated the fact that the muscle is a key contributor to breast contracture in certain instances. So they propose that after radiation, the clinical diagnosis of capsular contracture is inaccurate because it's muscle fibrosis that's contributing to the pathogenesis. So this is very interesting to have in the back of our minds, especially if it's a client that's suffering with this and they've had radiation and they can't seem to get an improvement. It may be in the muscle and not in the breast tissue itself. So let's look at some medication. So this, I found this list and first got interested in it because when I started taking clients after just cosmetic breast augmentation and the surgeon sent them to me for massage and to show them their self-massage after their cosmetic breast surgery, they would always get one of these first medication, that this leukotriene antagonist would always be on their medication form. And I just thought to myself, that's interesting because in a prescription form, it treats allergies. So I thought when I did my first search, I said, wow, like a lot of people in San Diego seem to be having allergies now. And one of them mentioned, no, they hadn't been on the medication long-term from their physician for allergies. They had been given it by their plastic surgeon. So what's really important to know is these leukotriene antagonists, some of them have a side effect, which is suicidal ideation. So that's important to me as a massage therapist, that when I see that, I want to know if they are on it short term, just started on it, or on it long term. And because I feel like our 1 hour conversation while they're getting their massage is an opportunity that they might share that they're having these new difficulties, and that I can say, hey, I want you to talk directly to your plastic surgeon about this because they gave you the prescription for this medication, and talk about this potential side effect that you're having, because it may be a side effect of your medication. It may not just be like post-surgery blues and you're going to get over it. So that's my little personal story and PSA for those leukotriene antagonists. And then looking at, they work in certain and different ways, which you'll see tamoxifen is on here too. They work in different ways, and they've been all in published research. So a surgeon may potentially put their clients on these medications, and we need to understand the side effects of these medications if we see them on our client's health history form. And this is something I go into more detail with in my class, the breast massage after implant and explant plastic surgery. But this is something on a case-by-case basis, like go ahead and look at the side effects and the indications of every medication that your client's on when they come to you. Because potentially one of the side effects may be edema, which is something I love to talk to clients about, because the edema may not be from the surgery, it may be from one of the many medications they're on. So let's talk about my particular advice on massaging clients with a breast cancer history after their implant-based reconstruction. So I see clients 1 to 2 weeks post-op if they have liposuction. I want to know from each and every different client whether they're self-massaging their breast, whether their surgeon wants them to come to me for self-massage of the breast, or because we're reducing the swelling from the liposuction area. Because I have a form that they have to sign if I'm going to touch their breast tissue. And I want to make sure that everybody knows that I'm massaging their breast, because if they have a mesh put in, I'm not massaging them 1 week later. I want to have the plastic surgeon to approve if I'm massaging the breast when they have a breast implant in there. So for the liposuction cases, I start as soon as 5 days, but I can start 1 to 2 weeks and everything is fine. I'll see the client. If there's a lot of swelling, they're very anxious about it, I can see them twice. The first week, usually I see them once a week for a few weeks, and then once every 2 weeks for a few weeks. And then if they want to come, because they enjoy the massage and they are still feeling benefits from them, they can come on a monthly basis. But most usually are like, this is fantastic, I feel so much better. And then they'll just go to their regular massage therapist for relaxation massage. I would like to see improvements after their massage visits. I talk to them about manual lymphatic drainage is going to make you urinate more. That's your swelling leaving the body. And the manual lymphatic drainage and the post-op massage I give to them should make them, if there's a heavy, tight feeling, like pulling taffy in the morning, if they feel tightness and stiffness, this should loosen it up. The massage should make them feel looser that day. They should feel lighter, and it's easier for them to have, full range of motion and get off the table immediately after massage. And that should last for hopefully half a week. And then when they feel like they're not feeling that amazing benefit anymore, they can come in for another session. Like our lymphedema patients, they should have a compression garment. They should have foam inside of their compression garment. Massage of the breast implants is led by the surgeon, so I want the surgeon to sign off about it. Let's see. And I show the client self-massage, lymphatic massage. I show them self-massage. If their partner comes, I'll show their partner, and their family can massage them in between our visits. And then don't only focus on just the breast or just the liposuction area. Also think about, in a bigger universe, what is going on with them. They underwent this entire cancer surgery and recovery journey. So they may have impaired shoulder range of motion. What can we do as massage therapists to help their shoulder range of motion? If they had a drain after their breast surgery, that drain scar is often very irritating to them, and it's pulling and it's sore. What can we do as far as scar massage on their drain scar? Neck and back massage, they're usually sleeping in an unusual position on their back elevated, especially if they're a side sleeper. This is not their usual sleeping position. So they have a sore neck, they might have a sore upper back. I'm just using what I learned in Massage School for neck and back massage on the clients. And then Are they having impaired range of motion after radiation? And if you have the skills, you can help them or else refer them to the physical therapist. If they had breast cancer, they should have access to physical therapy, and they should never think that just because they survived breast cancer, that means they should not put their hand up and say, hey, I still need more help. They should definitely be encouraged because people want and people are trained to help them get their good range of motion back and have all their activities of daily living after their cancer journey is complete. And there's a really great class, close training. I went to the close training, the breast cancer rehabilitation class with Jody Winnicor. And so I would recommend that if you wanted specialized training on helping people after breast cancer surgery with radiation. And I think they even came out with a part 2 for that class. So that's a really great resource as well. Okay, so let's talk, and we're in the home stretch. So let's talk about breast implant illness for just a moment. And I have much more deep resources in this if you wanted to research more, but I just want to put a slide up now. As oncology massage therapists, don't feel guilty if you're trying everything you can to reduce fatigue, joint pain, headache, muscle pain, inflammation, sleep issues, and more. And we're banging our head against the wall and we're not getting anywhere because these are some of the symptoms of breast implant illness. So this is seen more in clients if their breast implants are older. It's seen more in clients if they have autoimmune issues. There's a lot of research, published research out about breast implant illness. There is a resource on the FDA page about breast implant illness, which is where I send people as a first resource because it's the Food and Drug Administration. There's a lot of emotional conversation and controversy about this issue. So I think it's best if we just look at really solid published resources on it and get our information from very trustworthy resources. So this is a good first read to look into the systemic symptoms that may happen in some women who have breast implants. So the treatment for this is to remove the breast implant itself. Okay, so it was the tour de force of all the information that's current and hot about breast reconstruction, especially in the past 10 years. Thank you so much for bearing with me throughout this presentation. If you want more and deeper information on this topic, I have an online class. It's called Breast Massage After Implant and Explant Plastic Surgery. It is completely online. You can take it at any time in any time zone. And it qualifies for 8.5 continuing education units, and I'm a NCTMB approved provider. And if you sign up for the class and you email me and tell me you signed up for it because you saw me on this presentation, I will email you a free copy of our paperback that is our study guide. And that will really give you, if you're like a highlighter girly like me, you can highlight, you can circle, and you can, there are some like drawing activities that I included in the study guide, and it will really help you as a resource to have in your office. So if 6 months from now, 2 years from now, you remember like one of the, you're looking at a client and they have like double bubble and they have symastia, or it's one of the things that we talk about in class, or you have a client that has one of these drugs on their health history form, you can go ahead and look and get the resources and look at the information in the study guide. So that would be something that I would definitely recommend to email me, and then I will be able to mail you a copy for free because you found the class from this presentation. And as always, please follow me on Instagram. My Instagrams are my name, Kathleen Lisson, and then also stress reduction for lymphedema if you help clients with a lymphedema diagnosis. And then the link to this this PDF PowerPoint and all of the PowerPoints that in all of the other presentations that I've delivered is all on my website, KathleenHelenLisson.com. Okay, so these are my resources and we are all set. So thank you very much for listening in, and I hope you got a lot of information that will improve your ability to help our clients with a cancer history. Thank you and have a great day.